Thank you very much to our speakers. I think I'm going to hand over now to my co-chair to facilitate the questions and answers. Over to you.
Thank you so much, Dr. Michael, Dr. Mercy, and Dr. Andrew Schreiber. We note no questions on the app, and we understand. You are welcome to make your way to the mic if you wish to ask some questions. We have some time for questions. But I just want to reflect, Dr. Mercy, since you were the last speaker, that, particularly what was quite interesting is the finding of demand reduction or supply reduction, because that is one of the big priorities in drug policy plans or drug master plans, is to reduce the supply of drugs in a country. But you, in fact, actually found that the supply reduction created a situation of a health crisis for Kenya, which relates to your hepatitis findings as well as your overdose management. So that was a critical area. And so my question is, are our countries geared for supply reduction?
Thank you for that question. I can say for a fact that as Kenya, we were not prepared back in 2011 and our focus was mostly because of our law that using drugs, being found with drugs, because of some of the acts of parliament we have, there was no preparation that even when we were arrested, what do we do for you? So we do not have proper guidelines, proper policies that now directs you that if there is a reduction in the supply, then what next to address the health impact? Even when it comes to alcohol, we've also seen the same with alcohol, because we also have these times when the government raids places where alcohol is being supplied or being the illicit brews are sold, and you end up with the whole public in withdrawal and death. So a lot of times our systems, our healthcare systems, are not adequately prepared to deal with the health crisis, and that is because also the separation between health and the criminal justice system, instead of working together, they work in isolation. So these two have to work together so that you address all the needs. As you address the supply, you're also addressing the harmful effects that are associated with drugs.
Thank you so much, Dr. Mercy. We wait for colleagues to come in. You are absolutely welcome. Go ahead.
Hi, my name is Jesse. I'm a researcher at University of California, San Diego. So obviously a lot of the early research on harm reduction was all based in the West, in Europe and in the US and Canada. But obviously we also know that harm reduction is very much not a one-size-fits-all approach. And I guess this is for everybody on the panel. In what ways would you say that harm reduction programming in Africa has been specifically tailored to kind of your country's cultural contexts? And how might that be different from the way that we do harm reduction in California in the US, for example?
Thank you very much. Could I ask Dr. Michael maybe to respond to that, and every other person from the panel will have an opportunity as well. How has our harm reduction efforts related to our cultural context?
All right, thank you very much. That's actually a very important question, because truth is, when you consider the local context, it has a lot of impact on the harm reduction, and I would say in some instances positively, but quite in a lot of cases negatively. Positively in some instances because you find community gatekeepers and traditional rulers with whom you can work with as allies, and then you make advocacies to them, and they help you to, win over their subjects. But also negatively oftentimes because, again, the culture takes very badly to substance use. Oftentimes, people who fall into substance use become outcasts by the society. They thrown out without support. Oftentimes, they stripped completely of any opportunities to make a living or get by, and end up in very bad places, oftentimes with the law enforcement and in jails and all of those. So it becomes a problem, and then you also look at how the society and the culture looks at it when it's a woman involved. So for a man alone, it's a problem, and then a woman is having substance use is almost a taboo. Okay, so it becomes such a big problem because a lot of families then hide their clients or their wards or their children and do not disclose these issues, and then you have to do a lot of work to actually get them to open up and come forward. So in adapting the harm reduction to the local context and the culture, what we had to do was to first and foremost let everyone know that this is a prevalent problem. Almost everyone is going through the same thing. And then we had to get the community gatekeepers and influential persons to add their voices to it, the clerics, the clergy, people in influential positions, traditional rulers as well, to say, yes, we know that it's probably aligned to our culture, that people should be involved in this, but now this is a reality, and then there is a solution. So yes, it does retain quite a lot of what you have coming from the West because the strategies and the science is the same. However, we've had to adapt to the local context because we understand the culture that pervades. And it's actually getting to find that middle ground where you have a handshake between this coming from the West and what is locally the problem that has been for us the solution, and why we've been able to make some progress. Thank you.
I think I'll just add that the science may remain the same, especially when it comes to dosing and all that, but the social needs, what you found for our program is the social needs of people who use drugs in our context need to have a different way of being addressed. For instance, in our country, we don't have a system where the government provides free housing or gives you money. So what we have done is become more innovative, and that is why you see a very close partnership between government and the civil society and the people who use drugs, because you have to have the civil society arm to help you with creating a way of integrating these persons back into the society, be it by linking them back with their community, be it by providing them with sustainable livelihood activities, and creating networks where they can actually feel they have a family they belong to. So that is how we have found it's culturally adapting to our Kenyan system. The other thing is women. We really castigate women who use drugs in our Kenyan culture. So providing safe spaces where women can feel accepted, that despite being people who use drugs, they can still become back to be members of our communities and feel respected. Thank you.
So I don't think we've had the chance to adapt harm reduction in South Africa to our local culture. We've only been able to implement what funders have allowed, which is an HIV focus. So I think, initially it only focused on people who inject drugs. It only focused on opioids. So we haven't had that opportunity, and that's the reality, because that's where the funds were. But I think now we're getting to the stage where there's a recognition that there are people and technologies that can be more adaptive. So I think there are things that are culturally unique, but we have not been able to implement them because we haven't had the policy space or the funding. I think very much in linking people to family is really important as support structures. But also, I think the reality of homelessness is, particularly in South Africa, is important, and we have to be pragmatic. We cannot house everyone. And also lowering the threshold of our workup. So as a clinician, I'm very for simplification and doing as few workups as possible and taking a street medicine approach to harm reduction. And that's maybe not a cultural thing, but it's a very important contextual reality. And I think we need to simplify, and really do as little additional workup as possible, in a safe manner, of course. And I think we've shown that take-home dose has been very effective in the South African context. So most people will be on take-home dose within 3 months, unless there's a concern, and we can provide up to a month's supply. So not always the case, but I think the context maybe is as important as the cultural issues.
Thank you so much, Dr. Andrew. And just to also note that if we're not looking at innovative approaches like street medicine, we're not going to see expansion. We're going to continuously implement in a very expensive, perhaps a westernized culture way that is not appropriate to our economic circumstances or cultural context. So thank you for that. Sir, your hand, or you standing by the mic, you are welcome to ask your question.
Thank you very much, Yolan. I'm Reginald Khwedi from the people who use the drug sector in South Africa. Messi, I was above, your presentation. Let me thank you all, Andrew and Michael and Messi for the profound presentation. But my question is specifically for Messi, particularly on your journey towards the harm reduction bill. I want to check, how did you actually go about, achieving finally to have the component of, drafting the harm reduction bill, and how does you see it as an intercomponent with the decriminalization of drug use within your country? And lastly, to check if you have the, having the bill, will it also allows to have your treatment and consumption room services within the country? Thank you.
Thank you. So, and thank you for that question. Reaching where we are with the harm reduction bill has not taken us a few months, so it's been a journey. And what we did is, right from the word go, from 2011, when we started the harm reduction programming, we have engaged the political class in the process. When we went to the field to learn from other countries, we went with the politicians. When we went to teach people about how to implement programs, we had people who were in government and who are in the political class joining us, so that they can understand, so that they can lobby even for funds allocation for this programming to happen. And out of that, we got people who are advocates for harm reduction. The specific person sponsoring that bill in Parliament, because this is a bill that has been sponsored by a member of Parliament, is a person who has been with us in the implementation of harm reduction program, has been in the political space for that entire period, and therefore, because of the understanding of the needs of their, the politician who is sponsoring the bill is from the city of Nairobi, where most of our voters are also beneficiaries of this program. So she sees it as something that is actually going to improve the health of the people that she serves. So that is one of the ways we succeeded. That, number one, we had political goodwill. And not just now, but in the entire journey. Then the second thing is also ensuring that also the policymakers, that the government also believes in this. So as government also, and I'm in government, we understand that this is a bill that is important to be passed. So also supporting that this bill, through government engagement, also has made sure that it has reached where it is. Then, and involving all the stakeholders, ensuring that you have forums where you have the inputs of all the voices and convening these people to draft this piece of law. So a multi-sectoral approach and also having political goodwill. It may not actually be looking at decriminalization of drug use, but more so in providing better access to harm reduction services. So it's more geared towards the health aspect more than the decriminalization aspect, and I guess that is why it is also easy to sell to the lawmakers. I hope I've answered you sufficiently.
Thank you, Dr. Mercy. I think the consistency in terms of a multi-sectoral approach is very key from what you're saying. We have a last question for the panel.
Thank you. I'm short, so I need to take this up. My question is again for Dr. Morsi. I mean, your presentation was amazing. I mean, there are lots of success, in terms of controlling the epidemics, in ensuring the community inclusion, cultural issues, policy level issues. So there's so many successes. So I'm just wondering, how all these successes have translated into financing, particularly in terms of securing the domestic funding from the government. So if there are, then, what is a kind of a contribution, or if there are not, like why, in spite of all these successes, all these, in spite of all these multi-stakeholders, why the government is not willing to invest in harm reduction? And actually a similar question to, Andrew as well. In terms of COSUP is exemplary. I mean, I work with Harm Reduction International, and I'm a big fan of COSUP. Like, we have documented it, and we use it a lot of time as one of the most comprehensive provincial, harm reduction programs, including social contracting, embedded on this. But in spite of this, why other municipality or other provinces are not able to take it? Or, what is the kind of, bottlenecks on this one? And also it ties up with the, a kind of, a national domestic funding as well. I mean, South Africa is the leading, leading country, in, as you also rightly said, in terms of the evidence, the advocacy, the leadership. Now it's, it's also co-hosting the replenishment. But in spite of all that, we don't see, the domestic investment in harm reduction much at the national level. So, what is your perspective on this? Thank you.
So perhaps Dr. Mercy first in terms of it, and then Dr. Andrew, and then we'll conclude also with Dr. Michael's perspective on domestic resourcing.
Thank you for the question and for the compliment. I'll take it on behalf of my fellow Kenyans. Again, it's a multilateral approach. How has it translated into investment by the government in terms of the resources? So it hasn't been easy. We can't just say that one day the government woke up and said, yes, we're going to take this up. We started with a very heavily donor-funded program. Almost everything was donor-funded, from the infrastructure to the staff who are working there, the commodities. However, we started the conversation earlier again about ownership of the government and a sustainability plan. So gradually over the years, of course, with the donor funding, the infrastructure was put up, and that is permanent. It doesn't change, except, of course, you may need to renovate or improve, expand. But remember, we're also talking of decentralization and taking the programs out beyond the central or the urban areas. So the most expensive bit is the commodities, the human resource, the programming bit. So the government took up purchase of the commodities, especially like the methadone, from a very early stage of the program, methadone program. So purchase of the commodity being owned by the government, and then absorption of the human resource gradually. And this both at the national government level and the county government level, because I said we have two levels of government, and the health system is devolved. So county government level, they were encouraged to gradually absorb the staff members who had been hired for the programs. And you see that there's almost 100% transition of that human resource into the government payroll. That ensures that there will be no gap in human resource, because when you break the human resource aspect, then the program can easily collapse. Again, the commodities. But there are still some commodities that are still very heavily donor funded. So those ones we are still working to ensure that we can get also government either to invest or to get other donors or funders for the same. So there are still some gaps, but we are working on them. So a sustainability plan from the word go, and gradual phased absorption of the role by the various levels of government. Thank you.
So I think in South Africa there's a very negative moral view of drugs, and that is really the prevailing position. So I think it's really the individuals that are making decisions have moral views against people who use drugs, and it's linked to stigma. And I think that's the bottom line. And I think in the city of Tshwane, it happened to be an opportunity where there were the right people in decision-making that were open to evidence and to change through academia, through the university, and it's been a really good investment. But that's also under threat if it's going to continue, if it's going to change, because it has shown resilience. There were attempts during COVID to try and replicate the system in the city of eThekwini in the district, and they just couldn't find the political will to overcome the barriers, because they're all minor bureaucracy that can be resolved. So I think it's just stigma. actually.
Okay, so for Nigeria, domestic resource mobilization for us is the future. It's a conversation we're just beginning to have. Everything we have at the moment is donor funded, but then we know in light of sustainability that we have to do better. And then we're asking ourselves the question, how do we come about that domestic resource mobilization, especially given that not a lot of people are keen to talking about harm reduction and then saying they have other priorities by way of infectious diseases and what have you. But we have identified two possible streams at the moment. First is the fact that we know there are people that are well-to-do and can afford to pay out of pocket for these services. We do have it on record that some families pay huge amounts of money to access these services in private healthcare settings. Some people paying upwards of 6 million every month just to get these services. So those people in that category, we think, would find it a lot discounted to be able to pay for these services when as it now been provided by the government. All we have to do is expand the coverage. But then the second and the controversial stream we are currently contemplating, because we've also working on a bill just like Kenya is doing. And we are saying to the government, we are government too, but government department talking to another, saying a certain percentage of seizures and forfeitures, okay, coming from, because we have a very stringent drug law that once there is apprehension and prosecution, forfeitures of assets by such individual or whoever goes to the government coffers. So in our bill, we're packaging that argument that some percentage of such forfeitures or seizures should be used to finance harm reduction program. That's currently where we are. We don't know how they're going to receive the message, because already they're telling us that we're running afoul of an existing fiscal system that requires such monies to go somewhere, that we shouldn't talk about it at all. But we are currently engaging with the lawmakers to actually say people are suffering from these issues, and if you have some of that coming from prosecutions, it only makes sense that it should go to providing the solutions. So that's what we're looking to do, and hopefully it works out in the future. Thank you.
Thank you very much, Dr. Michael. It's very clear that to see sustainability and expansion, you need domestic resourcing to be prioritized and supported through political will. Or else we'll be facing higher costs in terms of managing a burden of disease as well as overdose management. So thank you so much. We have a last question, because unfortunately we have to close up, but you are welcome. Please identify who of the panel you're asking your question.
Good afternoon. Thank you very much, Yolene. I don't have a question, but it is a comment to Michael. In his presentation, he mentioned a sort of a dream to see Nigeria free from substance abuse. So I just wanted to say, it's okay, put it to dream. The reason being that we also have a blueprint strategy in the country, South Africa, which is the National Drug Master Plan, which also have the very same vision to see South Africa free from substance abuse. So it is not wrong of you to dream. One day your dream will come true. I thank you.
So thank you so much. My dream is that anyone that uses any type of drug can go into any clinic and access methadone or any substitution therapy or a needle. So that's my dream. So, your dream too, we dream together. So thank you so much for the questions, and thank you so much for the panel for giving that opportunity to answer those questions. Please maybe move over to our chair to close us.
Oh, thank you, Yolande, and thank you everyone also for staying up until now. I won't say much, I only have like a minute. So I think it's just to give a food for thought, kind of. After all is said and done, where does this leave us? Where does this leave the communities? What needs to be done for us to get to where we need to get to where all our dreams are getting us to? That's something to think about. We have seen and we have heard and we understand the challenges. We have talked about the funding limitations. We've talked about the punitive laws and policies. We've talked about discrimination. But at the end of it all, what needs to be done to get us to where we need to go to? Let's think about that. And thank you very much. Have a good evening.